All right. So again, we're going to start with chapter 8, which is about effective communication. So I will share my screen. Oops, that is not what I wanted. All right. So start off for our communication module. So, Maria Lopez is a 68-year-old patient. She was admitted to the med-surg unit with pneumonia. She has a history of hypertension and type 2 diabetes. Maria primarily speaks Spanish and understands only limited English. Her daughter usually helps translate, but is not present during the morning shift. The LPN assigned to Maria, Jamie, enters the room to administer medications and perform a respiratory assessment. Jamie explains the medications quickly in English while preparing them. Maria appears confused but nods her head. During the assessment, Maria repeatedly points to her chest and says something in Spanish. Jamie assumes Maria is referring to the pneumonia and continues the medication administration. Later, the RN enters the room and uses a certified interpreter. The interpreter learns that Maria has been experiencing new chest pressure and dizziness for the past 30 minutes. The RN immediately notifies the provider and initiates further evaluation for possible cardiac complications. All right, so for first, what communication barriers were present in that scenario?
Language.
Language. Absolutely. Language was probably one of the biggest ones, right? Um, so what cues suggested that Maria may not have understood the LPN's communication? And it can go back. So what cues gave us that were potentially that Maria did not understand what the LPN was saying?
Her facial expression.
Okay. The facial expressions. Um, right? She appears confused, right? But she still nods her head. What should the LPN have done when Maria appeared confused?
Got an interpreter.
Gotten an interpreter, right? Found somebody that would have, a professional interpreter. Why is it important to use a certified interpreter instead of family members when possible? What are some issues with that?
That they relay the wrong information or lie to them or something like that.
Okay, so they can relay the wrong information. They could lie. You're absolutely correct. Lay people too, they may not understand, right? Some of the things that we are trying to explain. Um, and then how could therapeutic communication have improved the patient outcome? So we talked about, right, for one, we talked about the use of an interpreter, right? And we look at communication, it's not always just what the patient is saying, right? It is the nonverbal communication that we have to pay attention to as well, right? She looked confused. People that don't understand, right? Especially when, and it's not just when they speak a different language, right? Even if we have somebody that is hard of hearing, sometimes even if they don't understand, right? They may nod their head anyway, and just to, make it seem like, okay, yeah, I'm good. So using therapeutic communication and really looking at all aspects of communication is important when we're working with clients, regardless of their ability to understand. So whether it's somebody that doesn't speak English, somebody that is, hard of hearing, or in within different cultures, right? Because some of the verbal and non-verbal communication may be a little bit different. Um, so it's important when we're talking and we're communicating with people that we're taking all those aspects into consideration. So here are some of the things that affect communication. So, oops, and I just hit um, sorry. So personal characteristics, things like age, right? We don't talk to, a a school age child the same way that we would talk to an adult. We don't, or even an adolescent, right? We don't talk to, a middle-aged adult the same way we may communicate with an older adult. Their gender, income, their life experiences, cultural characteristics, so the use of personal space, language, even values. Um, there's situational influences. So everybody's been to a clinical, right? How many have walked into, sorry, a client's room and the television's on 100, right? And you have to go in and have a conversation with that person, right? So I have to remove some of those, environmental noises to make sure that we are, they're able to hear us or we're able to hear them. Um, their physical and emotional state. So, what are some physical and emotional states that may be a barrier to communication? Ooh.
What was the question again?
What are some physical or emotional states that may be a barrier to communication?
Anxiety. They may have fear of what information they're going to receive.
Okay, anxiety. That's a good one. What else?
Depression. They may not want to hear what anybody has to say.
Okay,
Denial.
depression, anxiety. Uh-huh.
You're a what up?
The person isn't approachable.
They're not approachable. Okay. You walk in the room and they're already like this. Probably not the best time trying to have a conversation, right? What about pain? Right? If somebody is in a lot of pain, right, is that can affect communication as well, right? Odors, okay, walk into a patient's room and there's strong odors, that can be distracting, right? Not just for you, but maybe for the client as well. And then distractions, people coming in and out of the area, interruptions. And then, and I'm not sure who said it, but the circumstances leading to the conversation, right? If, somebody is, anxious, waiting on test results, and we're going in and we have to give them some, not so good information, right? That also can be a barrier to communication, right? Or affect the communication style that we are going to, experience within that, within that time frame. So there's three different types of communication, communications, I guess, I don't know, what is it, like styles, I guess. We have nonverbal, we have verbal, and then we have what's called affective. So three different types of communication. We know how powerful the spoken word is, right? Um, Once you say something, right, you can't bring it back, you can't pull it back. And so when we are talking with patients, right, they may accept what you say as fact, right? It's the end all be all. And so we have to be very careful with how we communicate. The nonverbal communication is also powerful, right? It either can support or it can cancel the meaning of what you're saying verbally. All right. So if I walk in and I'm standing in front of the classroom, and this is just an example, okay? If I'm up there like this and I'm just like, yeah, I really care about, making sure that you guys understand this material, okay? How would you feel if I said that like that? Do you feel like I really care if you understand the material? No, right? Because I look like, yeah, I'm not even maintaining eye contact with you, right? I'm looking all around. Or even if I was sitting here, at my desk lecturing to you, and I'm like, yeah, today we're going to talk about communication, right? Doesn't give you a good warm fuzzy about like my, wanting to share information with you, right? So we have to look at that nonverbal and the verbal communication. And so, it's about making sure that we are congruent with what we are saying as well as what we are showing to our patients. Affect, okay, is the feeling tone. That's the mood or the emotion. So it's how we're saying things and how things are being received by our clients. So again, verbal communication, this could be, what we're saying. It's also what we're writing. Okay, so it's our emails, it is our nurses' notes, okay? And then our nonverbal are a variety. This is our body language, this is our facial expression, right? And so, really making sure that when we are speaking, that everything is congruent. And then, of course, affect, like I said, that is the mood, the emotion behind it. So those nonverbal behaviors, again, facial expressions. Okay. So, what does your face look like when you are communicating with your patients? Um, you know, are you maintaining eye contact? Um, so, like, I have been told previously, like, I have what's called an RBF, and I didn't even know what that was until one of my students explained it to me. Okay. And this was many years ago when I first started teaching. And I was like, and honestly, I was like, what does that even mean? And so they were like, sometimes when you just look like you're mean. And I'm like, oh. And so I never paid attention really until that point, never really paid attention to what my face looked like. And so I'm wondering, like, I went to go back and I'm like, wow, if my students feel that way, I wonder how my patients feel, right? And it's not intentional. I'm really a nice person. Sometimes though, when I'm really thinking about something or I'm hyper focused on something, I don't always pay attention to what my face looks like. Right. So I've had to really pay attention and make sure that I'm presenting myself appropriately because I don't want anybody to think that I'm unapproachable, right? Or mean or anything like that. Distractions, gestures. So I know I think I probably told you this on the first day of class. One of the reasons why I keep my camera a little bit higher is because I talk with my hands and my hands go a mile a minute. Okay. Um, and it can be distracting. And so, I've had to work on that too, not only when I'm teaching, but when I'm working with clients, right? Because it can be distracting if my hands are going in the middle of, a million different directions when I'm talking, right? They may be more focused on what my hands are doing than what I'm saying to them. Posture is another one, like I was showing you earlier. If I'm sat back in my chair, my hands are folded across my chest, or I'm just like, yeah, this is fun, right? It's not showing that you're interested in the conversation that, you're having with that patient. And then fidgeting. So fidgeting is also one thing that's, part maybe that's why I move my hands so much when I'm talking. Excuse me. So, try not to fidget. There's strategies if you're a fidgeter. I had to learn a couple strategies to assist with that. Whether it's holding something in my hand that prevents me from moving it around. Um, Sitting in a chair that doesn't swivel probably would be a good idea too, because I will swivel in my chair. But just, maintaining focus on your client or the person that you're having the conversation with. You don't want to put your hands in your pockets. That also can, show them that you're a little bit bored or not paying attention. So like I said, everybody has different things that they may have to overcome, and just kind of trying to figure out what works for you. Yawning is another one. Oh my gosh, if I sat here and yawned the whole time we were on Zoom, right? That's not going to give you a big vote of confidence, right? In how I'm presenting information to you. It shows that we're bored, uninterested. And I get it. You may be tired. You may be tired. Um, And so, try not, we know it's not just out of boredom, right? But want to make sure that you're not, yawning and doing all that in front of your clients. Excuse me. Um, so these are some different active listening behaviors, okay? And so it's restating, it's clarifying, it's reflecting, paraphrasing, minimal encouraging, silence, summarizing, and validating. So we're going to go through each one of these, and I'm going to use the examples that are in your textbook to try, or to explain them to you. So restating is repeating what the client said in a slightly different way. Okay, so you are just repeating what the client said back to them. So if the client says, my chest hurts, I can't sleep at night, then example of restating would be, you've been unable to sleep at night because of chest pain, right? So um there's there's that. Clarifying is asking questions in response to a client statement to be sure that you understood. And when we clarify, we want to use closed-ended questions. All right. So what's the difference between a closed-ended and an opened and open, can't even say it, a closed-ended and an open-ended question? What's the difference?
Closed is like yes or no. Open is like room for more discussion.
Very good. With closed-ended questions, we want a very specific answer, right? A yes or no, something along those lines, maybe pointing to an area. But with open-ended, we're trying to elicit a whole lot of information. So again, with clarifying, we want to do a closed-ended question. So if the client says, my chest hurts, then you can say, okay, exactly where does your chest hurt, right? They can point to an area on their chest where their chest hurts. Reflecting is putting into words the information you receive from the client at an effective communication level. And I know that restating and reflecting and paraphrasing sound very similar to each other, but they are a little bit different. So with reflecting, if the client says, I'm sick of seeing healthcare providers and not getting any answers, then your reply back to them could be, okay, you're upset with the lack of answers to your health problems. It sounds different. I mean, it sounds similar to restating, but it is slightly different. Paraphrasing, everybody has done paraphrasing before for writing a paper, um, or something along those lines, right? Paraphrasing, you're expressing in your words, okay, what you think the client means. So, for an example with that, um, if the client says, I don't feel like I'm being, or I don't think I'm being told the truth about my condition, the paraphrase for that would be, you believe you've not received all the important information about your health condition. Okay, so they are similar, they sound similar, but they are different. Minimal encouraging, and we've all used these, okay? These are sounds or words to encourage the client to continue. So things like, okay, yes, tell me more, go on, uh-huh. You're kind of just encouraging them to continue to talk. Silence, this is one that a lot of people have problems with. Okay, so remaining silent, this is where you're pausing. Um, and for most of us, and I will say me included, sometimes this is a difficult thing to do. Okay, we want to feel that, that silence can kind of be uncomfortable, right? You're having a conversation and all of a sudden it kind of just stops and you're like, okay, what do I do now? Right? Do I ask another question? Do I say something else? Like, what do we do in those situations? Every, 5 seconds of silence can feel like forever. It absolutely can. All right. But silence is important. Okay. So there's a lot of times we can use silence. For one, when we're communicating with an older adult, right? We ask them a question, right? Sometimes it may take them a little while to process the question, recall the information, and then be able to answer those questions. It could be that we're having a conversation with somebody and they just received some bad news, whether it was a diagnosis, a test result, right? And, we just need to sit there with them and be a comfort to them. So again, a lot of people uncomfortable with silence. But we have to understand that it is very important, part of our communication and that it is going to happen. And so the more comfortable that we get with silence, okay, the better off we are. And then summarizing kind of goes into validating. Okay. So you're interviewing your client, you're getting that assessment information or whatever the reason for your conversation is. And then you're going to just go through the list. Okay, Mrs. Jones, you're here because you're having chest pain. It's a 7 out of 10. It's, in your, left upper chest. I don't know. Maybe they have some dizziness, a headache, whatever. So this is what I heard you say. Is that correct? All right. And then validating allows the client to either say, yes, all of that is correct, or no. Okay. It's not a 7 out of 10. Maybe it's an 8 out of 10. Okay. So you're going to summarize the information and then they're going to be able to validate that information back to you to make sure that you heard what they said correctly. So we already talked about the types of questions, right? So we have, again, those open-ended questions, and that is, that therapeutic communication. And so open-ended questions, right? Who, what, where, when, why, all of those wonderful things. And then closed-ended. Those are questions that require a specific answer, like when did the pain start? Show me where the pain is. Whereas focused questions are going to provide even more definitive information. So this could be on a scale of 0 to 10, with 0 being no pain and 10 being the worst pain, right? Where are you? Okay, so how would you rate your pain? So different types of questions are going to elicit different types of information from our patients. Other parts of communication, okay? And so, when we're building that that therapeutic relationship with our patients, it is really important that we use this therapeutic communication styles. And so we always want to be open, we want to be honest, we want to have integrity as well as dependability when we are communicating with our clients. We also want to use I messages. And this is something um, not many people really pay attention to. But what are iMessages? Has anybody heard the term iMessage before? Yes, no, silence. There we go, right? There's that moment of silence.
Are they pretty much like I statements, like and what I would do or how I feel you should moving forward, like giving your own
Okay.
opinion?
Okay, so iMessages, yes. They're very effective. So let's see. How would I do it? Now, this is just an example, so no, you guys are just not paying attention and I'm getting really tired of this. Like, this is ridiculous. How did that make you feel? Because I saw people look up. But how does that make you feel when I said something like that?
Kind of attacked.
Attacked, right? It puts you on the defensive, right? Like, wait a minute, we are paying attention. What is she talking about, right? But what if I said it this way? Um, I feel okay, that you're not paying attention to me. What can I do to make it better? How does that come across?
It's more compassionate and it's also like more validating to the audience and then allowing for open feedback as well.
Right. So I'm validating my feelings, right? And I'm not projecting them on you. And so when we use statements like, oh, I can't believe you smoke, that is horrible for you, right? Those are going to automatically put people on the defensive, right? So we use I messages um to try to avoid that situation. So um like, oh man, that was the best one I had. But it's really important that we kind of use those techniques. Again, we don't want, our job is not to put our patients on the defensive. Now, are all our patients going to be the easiest to communicate with? Probably not. Okay, are there going to be situations where you really get frustrated with a patient, right? Okay, yes, probably. All right, so remembering how we can tone back the conversation so that we don't put them on the defensive. Establishing eye contact. Now, eye contact is variable. Okay, I'm going to say that. In American culture or here in the United States, eye contact is something that we do, right? We're taught eye contact to maintain eye contact as a sign of respect. Do all cultures maintain eye contact? Very good. No, right? So while it is, we are going to try to maintain eye contact with our clients, we have to remember that they may not always do that depending on, their culture, their race. It may be a little bit different. Positive thinking, okay? And I'm not saying going in and saying, everything is going to be absolutely wonderful and it's great and okay. That is not what I mean. But you want, right, when we have somebody that is, depressed or even sometimes anxious or even maybe had a bad diagnosis, right? It's not going in and saying, oh my gosh, everything is going to be okay, right? But we know that positivity has a good effect on us, right? Positive energy, those kinds of things. Like, okay, so, you got a bad diagnosis. What are some things that we can do to try to help fight this, right? What, meditation, yoga, right? Some of that positive energy expressing empathy. So empathy is something, that everybody needs to have, especially when we're working with our clients, right? And what's the difference between sympathy and empathy?
Sympathy can kind of be like looking down on a person for what they're going through, and empathy is more so like sitting there and validating their emotions of what they're going through.
Okay. Okay, that was a good one. Yeah, so it's sympathy is feeling sorry for somebody, right? We don't want patients don't want us to feel sorry for them. All right. So oh, and you're, it's experiencing that emotion. Empathy is understanding and appreciate what they are feeling, okay? But you're not experiencing that emotion, right? You can have, excuse me, you can have two clients, okay, that have the same diagnosis, maybe even the same complications related to that diagnosis. Are they going to experience that the same way? No, right? So you may have had a similar situation to your client. Does not mean that they feel the same way about that situation as you do. So it is okay to be empathetic, right? Be beings, we want to avoid that sympathy. Always use open communication. Honesty, integrity is so important. And then we have this thing called self-esteem. Self-esteem is earned, it is not learned. Okay. No one can give you self-esteem and nobody can take it away. Okay. It is something that says, hey, it is okay to get credit for something that you did well, right? It also gives you permission to recognize that you have something special to offer. All right. And so again, self-esteem is earned, it is not learned. We can't learn how to have good self-esteem, okay? It is something that comes from within us and things that we do and we accomplish. And, not everybody has great self-esteem, right? Some people's self-esteem is a little bit lower than others. And so, if anybody needs a boost in their self-esteem, I'll give it to you right now. Look how far you have come. So, in your nursing program, you're in your last term. Okay. Nobody else did this. You did this yourselves, right? And each one of you should be proud of everything that you have accomplished so far. Like you would not be sitting in my class today, okay, if you hadn't worked hard, studied hard, and did what you needed to do, right? So yes, every one of you deserves a pat on the back for what you have accomplished so far. Okay. And if you ever need a cheerleader to push you through something else, please let me know. I will be happy to be there for you. And then the last part is always being aware of body language and posture. And I think we covered that, right? Just making sure that you're looking at your face, or you at least know what your face is doing, how you're standing, how you're sitting, right? Sitting is another thing. I talked about kind of, standing and talking to people, don't want to have your arms folded. You don't want to have your hands in your pockets. Sitting is the same way, right? When you're sitting and you're talking and having a conversation with somebody, you want to sit across from them. All right. Same kind of concept. You don't want to have your arms folded. You can, place your hands in your lap. Um, if you're sitting at a desk, place your hands on your desk. But again, you still need to be aware of your body language when you're, whether you're sitting or you're standing. Some of the other negative communication blocks. These are interesting, and these are interesting, and I know I've done some of these myself, not necessarily on purpose, but just not paying attention to what I was doing. But why questions? Why do you smoke? Why do you drink? Why do you do drugs? Right? Those can put somebody on the defensive. And so again, try to avoid those why questions. False reassurances, that's like, oh, everything is going to be okay. We don't know if everything is going to be okay. And I will tell you, this happened to me not too long ago. We had a very, I work skilled care. Okay. So most of my patients are there for some sort of therapy. Um, and we had a client that had had a recent stroke, and surprisingly, didn't have a whole lot of physical deficits, but definitely had some psychological issues. Plus, she also had some mental health disorders in conjunction with that. And I walked in the room because she was screaming. Don't know who she was yelling at, but it sounded like she was having a conversation. So I walked in the room and I was like, hey, how's it going? What's going on kind of thing. And she started telling me about how somebody had stolen $40,000 out of her checking account and burnt her house down and all of this. And of course, I couldn't validate any of this information, right? Because this isn't information that's going to be in her charts. Um, and so, but I also know that she had some cognitive deficits, and she had, she was also experiencing hallucinations and delusions. So it was really hard to tell, like, is this true information? Is it untrue information? But it was 3 o'clock in the morning and she was screaming really loud. And so I'm talking to her and I'm like, okay, what are some things that we can do? I'm like, have you contacted the police? Like, I'm just trying to, things. Meanwhile, she doesn't have a phone. So I know she wasn't talking on the phone. She was talking to someone that was in the room that wasn't in the room. And I had gotten her calmed down, and she, started talking a little bit more calm about the situation. And I said, it's going to be okay. And then I stopped myself and I said, oh my gosh, I can't believe I just said that, because then here it came. You don't know it's going to be okay. How can you tell me? And I'm like, I said, I am so sorry. I really didn't even mean to say that. It was just one of those things that just came out of my mouth. And I was like, so yes, I have done it. I have paid the price for it. So we want to be really careful because we don't know it's going to be okay, right? We don't know. Probing is another one. Probing is just pushing for information that we really don't need to know. That's where we just get like really curious about things and we want to know more. It's like getting the tea, but it's really not something that we need to know. Judging, this is another one too, right? you have your severe COPD patient or your emphysema patient who's still smoking 2 packs of cigarettes a day. And you're like, then that's why your COPD is acting up crazy, right? That's not our job, is not to judge, okay? Everybody has behaviors, okay? Some are good and some are not. Our job is just to continue to care for the client. We're not supporting the behavior. Okay, we're just providing that appropriate care. Belittling, mimicking or making fun of the client, go in and I'm like, okay, let's say you got to go in and give a heparin injection. And they're like, oh my gosh, it burns, it hurts. Okay, it's just a little stick. It's not that bad, right? We don't want to do that. Okay. Um, everybody's, again, everybody experiences things differently. So we do want to try to avoid that. We don't want to give advice. And I know this is hard, okay? Um, it can go even to the judging, right? We know that they need to quit smoking, but they've probably been told about, a million times, right, that they should quit smoking. But even it's, people know that you're in nursing school, you're going to be a nurse, your friends, your family. Oh, I've got this. Let me call Leanne because I've got this new pain in my big toe and she's going to be a nurse. So I'm going to ask her, she should know what to do. Right. Okay. Don't give advice. Or even if the client comes in, and or you go and talk to your client and they're thinking about their treatment options for whatever it is, and they're like, what would you do? Mm, don't do it. Okay. You want to say, and this, it's not really my decision to make. You need to think through, all of the different options that you have and make the decision that's best for you. Um, in additionally to even outside of work, with family, with friends, still want to be really careful about giving advice because if your advice doesn't work or something else happens, you could potentially be liable. You don't want to put yourself in that situation. And then try to avoid simple answers. Simple answers just feel like, you're not paying attention to them. You're not, what's the word I'm looking for? You're not, validating their feelings. So if somebody has a question, knowledge is power, and we know that the more information somebody has, the better off they are going to be, and then be able to make that informed decision. So again, try to give them as much information so that they don't feel dismissed when you're talking with your clients. And then this is just other things too with communication. Respect. Respect is a two-way street, and we know that, right? Always be respectful with your communication. Trust, talked about trust. Trust starts with your confidence though, too, and making decisions, okay? And so when you're performing a skill, when an instructor or a client asks you a question, right? You want to be confident in yourself when you're, presenting that information. Always be honest, all right? Show that empathy, right? Humor. Now, this is one. I love humor. I love making jokes. I love making people laugh. We do have to be careful with humor. We can, sometimes, it's just there to lighten up the situation. Okay. We do have to be careful with how we use humor. We don't want to make fun of clients. We don't want to use any sensitive topics with humor. Usually what ends up happening is I'll end up laughing at myself. Okay. Like I've gone into, start an IV or, hook up a tube feeding, take a blood sugar. I went in and take a blood sugar one night. This was like a while ago, and I had the little lancet in my hand and I had gloves on. And I went to hit the little button on the lancet and the lancet went flying instead of like poking. I was just like, okay, this is how this night's going to be, right? So usually it's me making fun of myself for something that has happened, right? So humor can be good, right? Everybody likes to laugh. Well, most people like to laugh, right? So sometimes lightening the mood, a little bit of humor is okay. Just be careful how you use it. And then we have our S bar, and everybody has heard of S bar before. And so S bar has, there's a couple different ways that we can use S bar. And so we have S bars for physicians calls. We have S bars for shift change report. And so it's the same as BAR. However, the information that we're going to provide in both of them are going to be a little bit different. Okay. So if I'm using it for a physician's call, okay, so I'm going to get my handy dandy phone and I'm going to call the physician and I'm going to say, all right, Dr. Jones, hi, my name is Jennifer. I'm calling from such and such hospital, such and such unit about Mr. Jones in room, 301. Okay, Mr. Jones has started complaining about chest pain, 9 out of 10, about 10 minutes ago. All right, I don't know, something along those lines. So it's your name, your unit, the client's name, and why you're calling. The background information is going to be things like your admitting diagnosis, when they got like their admitting date, like how long have they been there, what their current status is, and any information related to that. So obviously, if I'm calling about chest pain, I need to have some vital signs, right? Um, their medications, any allergies, are they on any IV fluid? What's their code status? Um, any pertinent MRSA medications, any mental status changes, things like that. And then the assessment is, what do you think is going on based off of the information? Okay. Um, if you should have already collaborated with your RN on this as well. But again, what is your assessment? Do you think it's life-threatening? Okay, so maybe Mr. Jones isn't having a heart attack. Maybe Mr. Jones is having an anxiety attack. Okay, not necessarily life-threatening, but definitely needs some intervention. And then recommendations are going to be what you need from the healthcare provider. Okay. What needs to be done? So, do you need the doctor to come see them? Do you need to order for a specialist to come see him? So maybe Mr. Jones needs a psych consult, right? Do they need to be transferred to a higher level of care? So if they're in a long-term care facility, maybe we need to send them to the hospital. Or if they're on a med surge unit, maybe we need to send them to the ICU, right? Do they need a higher level of care, or do we need a medication? Do we need to order for lab tests or urinalysis, an x-ray, right? So always have that recommendation. So again, when I'm talking to the doctor, always identify yourself, your name, your unit, the client's name, why you're calling, give them that background information, and then your assessment. What do you think is going on? And then for your recommendations, what do you want? Please have this information. So I always share the story. I was a brand new LPN. I was working. I had always worked a night shift. I had gone to day shift. At night, we very rarely call the doctor unless something really hits the fan, right? So I called the doctor. There wasn't anything seriously going on with the patient. It was a medication order that needed to be clarified. And first thing he asked me for were vital signs. Well, guess who didn't have vital signs? Because I was like, I don't need vital signs to ask for medication clarification. And so I was like, I don't have vital signs. And he said, call me when you have them, click, and didn't even give me a chance to respond. So I was like, okay, never happened again. Okay. Always had at least vital signs when I called back. So avoid those things, I made that mistake myself. And from that point forward, I've always had a set of vital signs just in case. Like, You're calling to get admission orders approved. I'm going to have vital signs. They don't even need the vital signs to get admission orders approved, but you're going to have them just in case. And never would have never let that happen again. When we're using SBAR for shift change report, a little bit different, right? Because I'm giving report to another nurse, right? Um, so obviously I don't have to say, hey, this is Jennifer, right? Because, going to be face to face, probably know each other, probably worked with each other before. So with this, we're going to do when we're giving patient turnover. Situation is going to be things like your admission date, the chief complaint, and the diagnosis. Plain and simple, right? When they were admitted, why they were admitted, and then the background information, all patient information that's relevant for care. So their history, their medications, their allergy status, their code status, other things like are they in isolation? What else? Any pain management, any lab results, what's their diet? Diet's important. Especially where, the background that I have, and we need to know if they're dysphagic. Are they full diet? Are they mechanical soft puree? Are they MPO? Um, what else? Mobility. Okay. Also, how do they transfer? Do they get up to use the bathroom? Are they one person? Are they two person? Or are they completely bedbound? An assessment is going to be all the other stuff, right? So what are their vital signs? Um, what are their glucose levels if they're a diabetic? What are any lab and x-ray results that may be pertinent? Are they a fall risk? Medications would also fall under assessment. And then recommendations are just the goals of care. So let's say, I worked day shift, the night shift is coming on. Is there anything that, related to that patient that needs to be done on night shift? Like maybe we need to get first morning urine on them, right? So that'd be something that night shift would get right in the morning. So always making sure that we're providing that information. And then, of course, do they have any education? Are there any discharge instructions that, discharge needs that need to be addressed? So again, we're going to use SBAR just in a couple of different ways, depending on who we're communicating with. Let's see. And then the last part of this is going to be our documentation, our charting. So charting and writing those nurses' notes, being very careful with this. Okay. When you are charting on your patients, you want to make sure it is accurate, it is factual. You don't want to put any innuendos. Don't want to put anything, any personal feelings. It is all going to be objective information, timely, thorough. There was one of the nurses that I follow, there was a nurse that had gotten in trouble, and I don't remember what happened now. It's been a while, but I will tell you the key thing that I learned from this. Um, she had documented that she had rounded on this patient at very specific times. Okay. And I don't remember what happened to the patient. Okay. It was obviously not a good situation if we were talking about it, but she had documented that she had rounded in on this client. And then when they went back to do the investigation, the times that she had said that she had rounded on her patient, they actually went into her cell phone. They got a court order for her cell phone and found that she had been texting and she was on social media and doing other things at the times that she was supposed to be rounding on her patient. So be very mindful of that. Now we understand that things happen. You may not chart exactly on time, but always, always be very, yeah, the duty log books. Yes. Always be very on time and be very, if it's a late entry, it's a late entry. But be very careful. Be very careful with it. Be thorough, but yet concise. Okay. you don't have to write a dissertation about your client. Okay. You want to put all the necessary information in there. And never use assumptions. Okay. So if you walk into, the client's room and they fell on the floor and there's a glass of water on the floor, you don't want to say, oh, they threw the glass of water on the floor so that they would fall, right? That would be an assumption. Okay. So you want to be careful, always factual. Um, Towards the ending. What do you mean towards the ending? You, so I know sometimes when we write, we feel like we are kind of leaving a hanging note, right? Like, oh, what else do I say? Whatever you don't have to have, it's not like you're writing an introduction, a body, and a conclusion. Okay. Oh, your own personal, it's really just, you don't have to, the only, how do I explain? That's a good question, and I'm trying to give you the best answer. Always use complete sentences, but all right, let's say I have a patient that is, um, let's say we have a tube feeder. I'll give an example of a nurse's note. So 0 to 100, um, I'll just say, for one, I'll say, okay, Jevity infusing at, 55 mLs per hour. Um, that would be my first sentence. And I would say, placement verified and how I verified placement. Did I use a pH strip? Did I aspirate gastric contents? Okay. Then, I'm going to say, residual 0 cc or 0 ml. So if I pulled back, there's no residual. If there's 50 cc or 50 ml is residual, I'm going to say 50 ml is residual, replaced. Okay. Because you don't ever just pull residual out. You always put it back in. Um, flush plug flush peg tube with 200 mLs of water per doctor's order. G tube site cleaned, new dressing applied. That's it. That's all you need to write. You don't have to have like a nice long dissertation about it. Um, just if let's say I had a client that was yelling like that lady I was saying earlier. I'm a little bit more, I guess, old school. So if I have a client that is yelling, I'm just gonna say, what they're yelling. Resident yelling out. Oops, so sorry. um, Resident yelling out, and just kind of what they're yelling about. I don't usually use direct quotes. Some I have maybe once in a while if it's very specific. But the only thing that really is just making sure that your notes are clear. Now, personal notes are going to be different. Now, and I'm not sure, Alma, really what you meant by personal notes. So I'm going to say this. Everybody has like a notebook or something that they write their own stuff down on, like your vital signs and any other, like if you go in a patient's room and you write down something real quick, right? Be careful with personal notes. Okay. um so Okay, documenting in the ER, yeah. So, yeah, you just be very specific. But what I want to say about personal notes, being that you did bring that up, be sorry, be careful with personal notes. Um, Everybody has them, whether it's like a notebook or something. For one, it could be considered PHI. But if somebody finds out that you have those notes, if something happens, they can subpoena those notes. So be careful I'll use paper when I'm at work. I'll write stuff down and then I put it in the burn box so I don't bring anything home. So you do have to be careful with that. Any PHI, any of that stuff needs to stay at the hospital. or at the facility. Don't ever bring any of that home with you. Cell phones. Oh my gosh. I don't know how to say it. Cell phones, text messaging, and social media. Please stay off your phones. Please stay off your phones. Um, Posting stuff about your job, about your clients, can get you in so much trouble. And if you've not seen it with, some of the nurses that have gotten in trouble, have lost their licenses, lost their jobs, you guys have worked too hard to get through nursing school, too hard to get through nursing school, right? Protect your license. The social media is a little bit out of control. Most places that you're going to work are going to have a social media policy. Your board of nursing has a social media policy. So make sure that you are aware of what the use of social media is, but taking pictures at work, be very careful. You don't want any patient identification or any patients in those pictures. I mean, most of them I've seen are in the bathrooms, but still. You just never know. And never say anything negative about patients, your employer, or anything like that when you're posting on social media. And then the last is conflict resolution. So conflict is going to be a part of life if it, everywhere you go, doesn't not just in healthcare, but there is conflict is it's something that occurs. It's natural. It can be related to stress, diversity, language, generation, personality. And so, we have a wide variety, wide diverse group of resident our clients that we are going to care for. Um, and so, especially when, high stress situations, things can tend to escalate rather quickly. So when we look at, basic steps for conflict resolution, first part is to accept conflict as a natural part of life. Everybody has different views, needs, everybody has different beliefs. Temper your own attitude and behaviors. Okay. Yes. This too. I'm a New Yorker by heart, okay? Born and raised. So this too, we have to be very careful about our initial reaction, right? Somebody is yelling at you. What is your first reaction, okay? Um, May have to work on that. I did have to work on that because I was like, I know you're not yelling at me. Like, but sometimes you do. You have to take a step back, take a deep breath, right? Don't always respond with your mouth and your fists, okay? You want to step back and be like, okay, how do we respond? Take that time to think critically before reacting. Um, Treat conflict as an opportunity to voice your own opinion and listen to the other side of the story. I know this is hard as well. Okay, but this is where those active listening skills and building that therapeutic communication, right, is going to come in. Um, and this could be whether it's client, be nurse to client, it could be nurse to nurse, it could be nurse to supervisor, right? Does whatever the client, whatever the conflict is. Some people, again, we just have to make sure that we are sitting back and we're just, we're, you're going to be able to voice your opinion, but we have to do it respectfully. Choose your approach. Okay. A win-lose approach is only going to escalate the intensity of feelings. Okay. So when we look at solutions to issues, we want to have a win-win situation, right? Win-lose situations are never going to be effective. And so we always want to go for a win-win. So win-win, it's your active listening, creative thinking, compromise, listen and learn. And this is, another thing. A lot of conflicts often are based on assumptions and a lack of information. Okay. And so, let's get all the facts and figure out what's going on. If you are wrong, and I know this is hard for some people too, if you are wrong, admit it, apologize, and move on, right? If we're wrong, it's okay to be wrong. People are wrong all the time. Some people don't like to be wrong, and it takes a little bit harder, it's a little bit more of a hard pill to swallow. Okay. But if you are wrong, apologize. And we learn from our mistakes, right? So now we know we're not going to make that mistake again. Just like earlier when I said, and I called the provider, I didn't have vital signs. Trust me, everybody has had a set of vital signs since that day, okay? Discover what's important, whatever the core issue is, okay? Whether it's, I thought that Rashida was talking about me behind my back, but when I sat down and, got to understand what was going on, Rashida wasn't talking bad about me, behind my back. Maybe she was upset with something that I said or something that I did, right? And so, that will help to, resolve that conflict as well. And then respect each other. Okay. We know conflict can be emotional, right? Doesn't matter where you're from, who you are. Okay. Conflict can be emotional. And so even if your feelings get hurt, even if you're angry, okay, you still want to be respectful and show respect. You don't want to blame, you don't want to name call, you don't want to, yell. But this is where those I statements are going to be really important to use. Okay. And then find a common ground. Okay. And so always try to find a common ground. Maybe we're not going to be best friends or not, whatever it is, but we can find a common ground that we can both agree on, and still be able to work with each other and, not have continued conflict. And again, conflict isn't just going to be with your clients. It also could be, with your coworkers and other things. So just beware that, and I always say go and do a deep, what's the word I'm looking for? Um, a self-analysis, I guess, would be the most appropriate way. Like, how do you react when people are confrontational? And so really kind of just like I said, you're kind of just going in and doing that self-analysis and seeing how you could potentially avoid being reactive when there's a conflict. All right. So any questions about communication, about effective communication, I guess would be the word I'm looking at. Nope. All right. So then chapter 9 is going to be, we're going to talk about assertiveness. But we are going to, okay. We're going to take a break real quick. Sorry. So it's 3, 5. 10, 10, 15. Be back at 3:15. All right. So we're going to talk about chapter 9. Oh my gosh. Um, I don't know what just happened to my computer. So chapter 9 is about it. The title, I think, is assertiveness, for this chapter. And so we're going to talk about the difference between assertiveness, and aggressiveness, and some of the different behavioral styles, when it comes to communication. So I'll share my screen. All right. Um, so look at behavior styles or communication behavior styles. We have three major styles. We have the non-assertive or passive communication style. We have the aggressive communication style, and then we have assertive communication. So non-assertive passive communication is fear-based. It is emotionally dishonest. It is a self-defeating type of behavior. So non-assertive nurses, they tend to look the other way. They avoid conflict. They try just to take the easy way out. They also don't express their own feelings, needs, and ideas, even when their rights are either deliberately or accidentally infringed on. Lack of eye contact, swaying, shifting from one foot to the other, lots of complaining. There's also hesitancy when speaking. And so the overall message with a non-assertive communication behavior is saying that I don't count, right? My feelings, my thoughts, my ideas, they don't count. You're the one that counts. And this will reflect in their nursing, how they care for their clients. They're often unable to recognize and meet client needs. With aggressive behaviors, okay, or aggressive communication style, this is basically just it's violating the rights of others. It's outspoken. It is an attack on a person rather than the behavior, so it's more anger based. Um, and so people that are aggressive, right? These are the ones that are glaring at you, leaning forward. And so it's more of a, it's an immediate reaction that somebody has like in the moment. And this again, it's kind of being like, um, you're not going to step on me, right? You're not going to, um, wrong me, whatever the word is that you want to use. It is, um, also, almost like a self-defeating behavior as well. Okay. They also, as somebody that is aggressive, they're not going to be able to advocate for their client, and take care of their clients appropriately. So what we really want to look at is assertiveness. Okay. Um, so assertiveness is another name for honesty. All right. It is a way to live the truth, okay, and to express the truth in thought, in word, and in deed. Okay, so you're taking a positive stand, you're being confident in your statements, you're speaking openly, but you're not violating others' rights. Okay, so it's very different from being aggressive. This is too, you're standing straight and tall, you're facing the person, you're able to make eye contact. And it's not just what you say, but how you say it, right? And that's something that we have, sometimes have to learn and understand. Um, you can express your opinions. You can advocate for your patients. You can advocate for yourself. Okay. And we can do this assertively instead of aggressively, right? Because you have the right to express your own thoughts and feelings, right? We just have to be careful when we have it because we don't want to violate the rights of others, right? So this is, you know, you have a inappropriate medication order and you need to call the provider, okay? And that's being assertive. Hey, this, I think this is an incorrect medication order. I need to get it clarified. It's not being aggressive. You wrote this order wrong. You need to fix it, right? It's more of like, just being assertive. Um, Advocating for your patients. All of those are just being assertive. You always want to own your feelings. You don't want to blame others for how you feel, right? Those I statements, again, are going to be really important. And always make sure that your communication matches. So your nonverbal and your verbal match, they're congruent. Negative interactions, coping mechanisms. So, we look at coping mechanisms. This is everybody has different coping mechanisms. Some are good, some are not so good. But some of those negatives, projection is one. Um, Individuals attribute their own weaknesses to others. Okay, so um this just kind of, I'm more competent than you are type of situation. You may also hear, well, you're only an LPN, right? Which drives me crazy. I didn't like it when I was at LPN and I don't like it now. Right? But that's projection. And so again, this is where your assertiveness, the nurses that are confident and that are assertive, right? They're going to work with each other. They're going to enhance each other's, knowledge, and benefits, right? It's going to be the client's also going to benefit from that assertive behavior. Rationalization is another one. Um, Rationalization is logical, but an untrue reason is offered as an excuse for the behavior. Okay, so sorry. So this could be, um, let's see, I'm trying to think of a good rationalization. Labeling a client as a troublemaker, or uncooperative. Okay, this is also a non-assertive type of interaction. And then denial. Okay, denial, the nurse can use this excuse to excuse personal liability, right? Oh, I didn't know that was my job. Or, nobody told me I needed to do that. Okay, so again, these are negative coping mechanisms. So, problem solving. How do we get to be more assertive? All right, so problem solving. Problem solving steps. So problem solving process, is a series of steps used to solve problems. Okay. This isn't, the nursing process, although it is very similar to the nursing process, but this was around a long before the nursing process was ever, around. Um, and so you're going to see some similarities. Um, sorry. Um, So it's a growth producing method of dealing with challenges in your life. And so anytime you have a situation where you require to solve a problem, you can use this process. So step one is define the problem. What's the issue? Sometimes what we think is the issue isn't always the issue, right? And so again, you want to identify and define the problem, right? What is the issue? And so it may require you to collect some data really to identify what the problem is. And then you can write a problem statement, much like, how you would use the nursing process. And then you want to decide on a goal. Okay. So you write out your problem, you defined it. And now, again, you can use the nursing process here, just like we do with the planning process, right? You want to decide on the goal. What do you want to do differently? Okay. And you can have a single goal, or you may even have multiple goals. You can have short term, you can have long term. Okay. It's whatever you feel is going to be, what you want to come, or what you want to come from this process. Again, just like the nursing process, they need to be attainable, they need to be measurable, and they need to be realistic. And then you're going to choose alternatives. So, what are, the approaches that you want to use to gain or attain your goal? Okay. So think of these as, your interventions, so to speak. One of your alternatives may even be to do nothing. Okay. That is, an effective intervention in some cases. It is a choice. And so, of course, it's going to depend on what the problem is and what what you want to happen as a result of this process. And then you're going to try out your alternatives. Okay. So again, this is like, does it work? Does it not work? So, whatever your, goals were, or whatever your alternatives to beat your goal, you're going to try them all out. And then you're going to go through the evaluation process. So I'm just trying to think of a good one. Let's say, what is your goal? Um, I'm gonna just do this. Let's define the problem is I want to go on vacation in 6 months, but I don't have enough money to go on vacation. Okay. So you're gonna decide on a goal. Okay. So maybe your goal is to go on vacation, and you have to have, this is probably unrealistic. Let's say you need $1,000 to go on this vacation. Okay. So your goal is to save $1,000. All right. How are you going to get there? All right. So you have alternatives. So let's say I'm going to put, $20 into my vacation fund, or maybe I'm going to pick up a couple extra shifts, right? So you're going to pick up different interventions, okay? And then you're going to try it out. Well, the saving money is actually working out. I'm able to save this money aside, but this picking up these extra shifts, right, is a little bit, it's hurting my mental health, whatever it is. Okay, so you want to try them out and then evaluate. Again, you have 6 months to save this money. Let's say we're 3 months in and I only have $50 saved, right? We got to reevaluate. What do we need to do? I need to start adding some more money. I need to, maybe what is it that I need to do? Right. And then repeat the process if your solution isn't effective. And so go back, still want to go on that vacation. Maybe 6 months isn't, is too short a time. Maybe I need to plan it out for a year. Okay. So it's just like the nursing process. It is a step-by-step process that we can use for problem solving. Again, very similar to the nursing process. But again, this, everybody uses a problem solving process. So it is, obviously been around for a long time. This chapter kind of goes a little bit, but overall, like around a bunch of different things. But when we look at aggressiveness, back down to aggressiveness and some work-related issues that we may come across. And I know everybody has social media, okay, whether you use Facebook or Instagram or Snapchat, or I don't know what else is out there. I'm so far behind on this. We, know what goes on in healthcare. Okay. Workplace violence has existed in healthcare facilities always. Okay. It is just now with technology and social media, the internet and things like that, it has become a more well-known thing that occurs. Okay. And so, the increase in violence, we need to make sure that we are prepared. So assault, okay, according to OSHA, which is the Occupational Safety and Health Administration, assaults comprise 10 to 11% of all workplace injuries. And so that's pretty sad. And that is triple the amount of what we see in private sector. Okay, so that's a huge amount. The Um, 54% of nurses will experience verbal abuse by clients, and then 29% will experience physical abuse by clients. Okay. And so, this is everything. So, you know, just always be careful. OSHA, okay, again, which is the Occupational Safety and Health Administration, they have published guidelines to prevent workplace violence. So OSHA is there to protect the workers, okay, from workplace violence. And they have also, have set guidelines about what organizations need to offer as far as keeping their staff safe. Now, I will tell you, um, not all agencies have complied with OSHA regulations, okay? But of course, we also want to, know that our, the nurses associations, are working to push this. I have heard some like just really crazy stories, where some hospitals have even pulled, their, security. And so it's just interesting. But the biggest thing is we have to do is we have to protect ourselves. Manipulation. Um, so manipulation is feelings and needs of others are disregarded or other people are treated as objects to fulfill the needs of the manipulator. And I'm sure everybody has worked with a manipulative patient, and if you've not, you will come across them. Manipulation, they use all sorts of tactics in order to get you to meet their needs. And it can be very difficult to work with this type of client, because it's like no matter what you do, it just never seems to be enough. Um, and so, the best thing that you can do is be assertive with that client. You want to make sure that you are setting limits with them. They often are going to be very resistant. They may even become resentful towards you. And if you can't work out the problem with the manipulator, then you may have to have to stop being involved with them. They may require another provider to go in, another nurse to take care of that client. Um, but these, hopefully, I mean, I've had some minor manipulators, nothing ever really, really, really expensive. But again, they can be very frustrating to work with. You're going to set your limits, you're going to be assertive with them. But if they continue their behavior and they're not easy, it's just not working, then you may have to leave the situation. Insidious aggression. Um, so we'll look at insidious aggression, aggressive behavior in the workplace. Okay. These are sometimes not, this is like more of your nurse to nurse, nurse to manager, but it's usually within the workplace. These are things like incivility, interpersonal issues, and hostile acts that may not be obvious to others. So when we talk about incivility, this is like nurse to nurse bullying, or, even other staff members. It could be supervisors, it could be managers, it could be administrators. It results in job stress, less job satisfaction, less job commitment, less satisfying relationships, higher levels of anger and anxiety, and lower levels of overall well-being, right? If you're being bullied at work, do you really want to go back to work no matter how much you love your patients and you love being a nurse? Nobody wants to continue to go back to a hostile environment, right? If you're being bullied or disrespected, right, it is something that is going to overall affect your mental health. And those that are subjected to insidious aggression are more likely to quit their jobs, okay, which leads to high turnovers. So let's say Liddy is picking on Ivana, okay, but it's not Like you can't see it, right? Liddy is not just, going up to Ivana and saying mean things to her. Okay, but maybe Liddy is talking about her behind her back. Or, maybe Liddy is just, doing things on purpose to try to get Ivana in trouble, right? It's not necessarily something that people can see, right? But it is something that happens behind the scenes and really can't put a finger on it. Um, or in take that same situation, let's say Lydia is bullying Ivana, okay? And instead of confronting Liddy, she just kind of like lets it roll off her back and has a very passive approach to it. Okay, in those situations, what's Liddy gonna do? Liddy's just gonna continue the behavior, right? And it may even escalate and get worse. Again, this is why I'm saying your assertiveness is extremely important. Stick up for yourself. You can be respectful. You can be within your rights to stick up for yourself, but nobody has the right to bully, to be incivil towards you. Oh, and that brings us to sexual harassment. So sexual harassment is not about affection or caring. It is about power, plain and simple speaking. Okay. It is abuse of power. It is unwanted. And sadly, most cases of sexual harassment go unreported, for a variety of reasons. Maybe they feel like that they may have some retribution against them, um, because of, the if you report it. But the first thing that you want to do is if you feel like somebody is making unwanted sexual advances to you, or you feel like you are being sexually harassed, the first thing you do is confront the person. Like, hey, this is, this behavior is, unwanted. It's, it makes me feel uncomfortable, whatever, however you want to do it. Um, but that is always the first thing that you want to do. And when you confront them and you tell them this is unwarranted, you need to make sure that your verbal and your nonverbal communication completely match. If the unwanted behavior does continue, that is, you report it to your supervisor, your department head, HR, whoever it is that you need to go to. But always remember, you have to tell them that it is unwanted. You have to confront them first. And I talked about this a little bit with, the incivility, and we have what's called lateral violence. And I'll tell you, I've been a nurse for a really long time, okay? And I remember all the way back in my bachelor's degree, I actually wrote a paper on lateral violence. So this is something that has always been an issue within nursing. But this occurs between nursing colleagues, all right? So this could be things like sabotaging, withholding information, backstabbing, right? You get your change of shift report, and they don't tell you that your patient's a huge fall risk, or that the patient, has certain things that need to be done or needs. So it is something that occurs. Again, I put this right there with bullying. It is never a good and safe situation. Again, this is going to lead to poor job satisfaction. Again, nobody wants to go to work if they're being bullied consistently. The vertical violence, this is the violence that between people of unequal power. So this could be you and your nurse manager. It could even be the nurse and the CNA. It really just depends. And the goal here is to humiliate and undermine. The person that is bullied ends up being fearful and unsafe. Again, if you're being bullied at work, nobody wants to go to work when you don't feel comfortable going. This is also one of those, things in civility that we talk about. So what leads to workplace violence? Okay. And so workplace violence, again, this isn't just the people that come in to seek healthcare. This is the people that we work with. Okay. So depending on the situation, but certain things that lead to workplace violence, um, personal factors. Okay. What's going on, in their lives, in their head. Um, what are, if they're, having some personal issues, right? Of course, that's going to be one of the biggest things that we need to worry about. But what are those personal factors? Body language. When we look at body language, pacing, balling up their fists, um, also increases, that risk. Environmental factors, and then certain risk diagnosis, right? Do they have um, a mental health disorder? Do they have a history of what's the word I'm looking for? Drug or alcohol use. Those are potentially, some risk diagnosis. And I'm sorry, I skipped this one with environmental factors. Where is the hospital? Where is it located? I know that sounds pretty crazy, but think about where the hospital is. It inner city? Is it in a high crime, is it a high crime area? Where the hospital is located is going to influence the type of clientele that are coming into it. And is it a psychiatric facility or is it just a regular emergent, a regular hospital? In that is something that we have to look at, too, that can increase your risk for violence occurring within the hospital. So these early signs, and I'm really big on situational awareness. And I don't know, has anybody heard the term situational awareness before? Yes, I know Alma has. So anybody else heard the term situational awareness? Nobody's heard that term before? Oh, I saw LaShonda's hand. Ivana went up. Okay. So situational awareness is just basically knowing where you are, who you're with, and what's going on around you. Um, and it's and I'm sure that you guys have heard things like when you're out in public, right? You don't walk with your head down. You shouldn't be, your head shouldn't be buried in your phone when you're walking, right? Your head should be up. You should be looking around, seeing what's around you, who's around you, what's going on. It's the same thing in healthcare. Okay. You want to have that situational awareness. You want to know who's around, what's going on. It's using all of your senses just to keep, it's basically here is to keep yourself safe. So, who's on the unit, are there family members, what's kind of going on. So when we look at early signs of workplace violence, unusual behavior changes, okay? They start to act a little bit different than they originally presented. Lack of cooperation, okay, whether it's with nurses, with other clients, with family members, start cursing or, yelling, screaming, other forms of hostile communication. They anger easily, right? So they have like quick switch. They spread gossip or rumors to harm others deliberately, like, just again, part of that bullying. Um, Uninvited sexual remarks, hostile responses, increased irritability and anxiety, um, again, spreading or they mentioned that they have some sleep disturbances. Not all sleep disturbances are going to lead to workplace violence. Okay, but if they start to see a pattern and they have more than one of these symptoms that going on, then that is something we need to pay attention to. As it starts to progress, okay, we may start to see then they may play the victim role, right? Poor me, everybody's picking on me. They may also start with notes, with threats. Um, or violent or sexual content. They may start to verbalize a plan or a desire to harm someone. They may start stealing property. They have less interest in work. They have increased arguments. They have increased physical accidents or injuries. And then as it continues to intensify, or the anger continues to intensify, and they're still having whatever the conflict is, then of course the result can be violence, whether it's against themselves or it's others. Okay. So if they, direct the violence towards themselves, right? Depression, suicidal threats, suicidal actions. If it's towards others, again, it could be physical. It could be, even using a weapon. So again, it's really paying attention. So we want to make sure that we are really focusing on prevention. Like I said, OSHA has guidelines. To help prevent workplace violence and to help prevent, to keep us safe. But everybody plays a part in this. Okay. So, knowing what your prevention guidelines are, participating in training. So OSHA will offer training. There's also, depending on where you live, you may also have opportunities. You may even contact your local police department. They may have some self-defense things that training that you can take. Otherwise, there may be some self-defense courses that you can take on your own. Remember, the focus is on gentle self-defense, okay, not offense. We're not going to attack our patients, okay, but we do want to, be aware of that. You always want to be prepared, before workplace violence becomes an issue. You want to try to be as prepared, get as much training as possible. You want to really pay attention to those those warning signs. And what you can do to try to prevent an escalation. But one of the biggest things that I really want to stress here, and we've seen this, so you can go back and look at the school shootings and other things that have happened in the past, right? And as they've gone, what have they heard? Oh, this was reported and that was reported, but nothing was ever done about the situation, right? And now we've had this huge issue arise. Take all threats seriously. This is one of the biggest things. It doesn't matter how big or how small it is, report them to management. Because like I said, right, anytime that the majority of the time that there has been an incident, there has been signs that something is about to happen. But because, and some people have reported them and they have gone unnoticed, but, reporting the things is going to be really important. And you always want to advocate assertively for prevention guidelines in your facility. And like I said, this could be, making sure that there is, enough security. I think one of the worst things we had, I worked for a facility. This was during COVID. Um, and we were initially part of a hospital system. And so if we had an issue with the facility, we could dial the hospital security, and hospital security would come. We were only we were less than half a mile from the hospital. But then they decided somewhere along the way, that hospital security wasn't going to help us anymore. And so I was actually the manager on duty one night, and we had a shooting in the parking lot. I mean, nobody died. But I mean, I had to call 911. And then I called hospital security, and that's when I found out, well, we're not coming. Like, you're kind of on your own. And I'm like, oh, that's nice. And we know most of the time long-term care facilities don't have any type of real security. But I will tell you, with COVID, that is one thing that kind of helped tighten up things. Because with COVID, we didn't just let everybody in, right? So that is one thing that was a little bit different now, is most facilities have locked doors now. And that's kind of a twofold reason. So one, it does help with security, right? Kind of know who's coming in and out of the facility. But yeah, so but I have been reading some things that saying that some of the facilities or some of the hospitals are actually like disarming their security guards now. So um some of them, I guess they used to carry weapons, but now they're not allowed to, they're not even allowed to carry like tasers or something along I don't know. Um, but like I said, always look to protect yourself if there is anything that is potentially dangerous or that you recognize anything that is potentially going to happen, that you report it. You want to make sure that you're safe. So I'm going to ask you some questions now. So let's say you are working in the emergency room and somebody starts um, yelling and screaming and verbalizing threats. What are some things that if you find yourself in potential danger, what are some things that you should do? And it's not always run out the back door. Some cases it may be, but what are some things that you should do for yourself? How should you protect yourself?
Well, you kind of want to see how bad the threat is. So, um, repeat the scenario again. You said it was somebody.
Well, it doesn't matter. If there's any potential situation where you're potentially in danger, what do you want to do?
You probably want to try de-escalating the situation. So,
De-escalation.
definitely try to. Maybe it's like a mental health patient who got access to a gun or something, and try to kind of not so much negotiate, but just kind of calm them down and then go from there.
Okay. All right. So definitely try to calm them down, try to de-escalate. Faith
Stay
said
close
keep
to
your
the
back.
door.
Yeah. Keep your back to the door. Don't turn your back on the person. So this is where your situational awareness comes into place, right? Always have a way out. Okay. And like I said, sometimes you may have to run out the back door. Okay. And I'm not saying that that's not going to ever be an option, but always have an escape route. Know where your exits are. Know if there's anything blocking those exits, what's in the way. Always. And when I say stand with your back to the door, okay, don't block the doorway. Okay. There's a difference. So you want to keep your back to the door, stand slightly to the side, but don't block the door. Okay, a couple of different reasons. If they're going to storm out the door, let them go. If somebody else needs to storm in the door, right, you want to keep that open airway. Stand open. So this is like that nonverbal communication, no hands in your pockets. You just want a very nice open posture. Open posture is going to be a lot less threatening to somebody, okay, than if you were to have your hands in your pockets, your arms crossed. They may think that you're hiding something. Call them by name. Speak in a soft voice, okay? If somebody is yelling, okay, yelling back at them is not going to help the situation. You want to bring it down because, for one, they're going to have to lower their tone in order to hear what you're saying. Okay, so you want to be soft, you want to be controlled, you want to remain calm. And I know in some situations this may be difficult, but you need to remain calm. You don't want to, again, you don't want to yell at them. You don't want to point at them. You don't want to try to touch them. You don't want to threaten. You don't want to intimidate. You are going to use that nice, calm voice to try to de-escalate the patient. Again, if you can't de-escalate, then, hopefully there's others, that will be available to assist you. But never, somebody said it, don't ever turn your back on somebody that is a potential threat. Okay, have that way out should you need it. And in some cases, you may absolutely need to have that way out, and that is okay. because you need to be able to protect yourself. And there are different de-escalation techniques, and so your your organizations may, help you with some de-escalation. They may have policies and, procedures that are put into place to handle those. It may be calling, like I said, it may be calling security or, somebody else. Um, but always have, get some resources under your gun, under your belt. Go to the OSHA website. There's, other things. I know when I was on campus, I did psych clinicals, and we did them through a city psychiatric, like outpatient. I don't know what it was called. Actually, I can't remember. Um, but as part of just as a clinical instructor, I had to go and I had to take a course. Can't remember what it was, but basically it was de-escalation. So in case one of the psych clients, because this was outpatient, so this was like a day program that they went to. We had to know what, first of all, we had to know what the policies were within the organization, but we also had to know what would happen. Because of course, as a clinical instructor, my first gut instinct, right, is going to be to protect my students and make sure my students are safe. But everywhere is going to have different policy and procedures. Even when I worked at Children's Hospital, um, we also had to learn de-escalation techniques and therapeutic holding, and other techniques, right, when working with pediatric patients, because just because they're pediatric patients doesn't mean that they can't become aggressive, right? There's certain risk diagnoses that are available, that are there with even with pediatric patients. So, like I said, I hope my hope is that none of you ever have to be in a situation like this. But it is going to be about protecting yourself. Okay. And so if you don't have good situational awareness now, like really start to build those skills. Anybody like soccer? Anybody watch soccer? No. Oh, Alma. So Messi, I don't know if anybody knows who Lionel Messi is, but he is like an amazing soccer player. And if you watch him on the um if you ever watch him on the soccer field, his eyes are always like he knows there's 22 players on that soccer field and he can tell you where every single one of those players are. And that's because he is constantly scanning. And it's not any different than really knowing what's going on. Just like I said, keep your head on a swivel and just know what is going on within your unit, that everything. Again, how to get out if you need to, and just keeping yourself safe. That is my goal. If you have that understanding, but it is something, and it's even when you're out in public, right? You never know what can happen, especially the way society is today. And so just always looking around, knowing what's around you, who's around you, how do you know if you're being followed, right? So again, just keep yourself safe. That is, if you get anything out of that, that is what I want you to do. All right, any questions? Nope. All right, so let's take a break. Be back at 4:10 and we will do chapter 14. All right. So now we have chapter 14. So chapter 14 is it's the interdisciplinary healthcare team. So your role as part of, as a member of the interdisciplinary healthcare team. Um, and so the IDT or the interdisciplinary team, whatever you want to call it, um, is just a group of professionals, healthcare professionals, and actually not just healthcare professionals, but professionals who will contribute to the care, as well as the treatment of a client. And so obviously everybody needs to display mutual empathy and understanding, work together to meet the common objectives. And the goal, of course, is to promote positive patient outcomes with an attempt to restore health or at least get them back to as close to a previous level of function as they were at. So I will share my screen. So when we look at the members of an interdisciplinary healthcare team, all right, so guys, all right, so obviously we know nursing is going to be a big part of that, right? So and that's going to be your RN, your LPN, your UAPs, whether it's CNAs, patient care technicians, patient care assistants. There's a variety of different terms out there for UAPs. It could be nurse practitioners, could be physicians, it could be surgeons, right? Depends on who the provider is. Case managers, okay? So RN case manager, dietary, lab personnel. You also have your social workers, your therapists, so occupational, physical, respiratory, speech, all part of that interdisciplinary care team. And in some cases too, when you're working in like a long-term care facility, um, we will also add activities. Okay, so your activities director, your activities personnel will also be part of that IDT. Feel like I'm missing somebody else. But generally, these are just kind of an overview of what some of those members would be. Um, and so there's also an intra-disciplinary team. And so an intra-disciplinary team are going to be healthcare workers of the same discipline that work together. Okay, so again, this is like your different levels of nurses. You may have like an RN and LPN as part of a healthcare team. So in different roles. So nursing roles in education. So we'll start with registered nurses. So registered nurses, they can do the 2-year educational program, right? Like in your community colleges and get that associate degree program. Or they can do the bachelor's program, which is generally a 4-year nursing program that you find in more of your the university type settings. Um, Difference between bachelor's and associates, obviously the different level of education, but bachelor's programs also emphasize nursing theory, including public health, which is a little bit different. A lot of your associate degree programs don't have a whole lot of public health, but different levels. They perform an independent role, and nurses RNs perform an independent role. In nursing, they are also interdependent, meaning they also will carry out orders. Um, they, what else? They can coordinate all the activities of care. They provide care that's a little bit more specialized. They also provide education. They act in their role according with their Nurse Practice Act, and there are national certifications that RNs can get depending on what area of nursing that they work in. There is a bunch of different certifications that are out there. You go, they can, there's emergency, there's med surg certifications. There's like I have a certification in managed care. So lots of different certifications. The advanced practice nurse, which is your APRN. This is an advanced degree. And this includes your like certified nurse, registered nurse anesthetist. It's your nurse practitioners, your nurse midwives, your clinical nurse specialist, your nurse executive or certified nurse educator. And they, again, this role is going to be practiced within their Nurse Practice Act. And then, of course, we have the doctorate degrees. So there's PhDs and then there's DNPs. So PhDs are research based, and then your DNPs are practice focused. So like, for example, I am in school for my DNP in education. And so I will find some sort of a practice gap to specifically address, something that, an issue among nursing students and try to fix that gap. And then we have our wonderful LPNs. So our licensed practical nurses, anywhere between a 12 and 18-month vocational practical nursing program. And these vary as well too. So like when I did my LPN, I went through a vocational program through like the vocational high school, local VOTEC. And so at the time it was an 18-month program. And so basically I went to school the same time as like the high school students did, except we did ours at night. Some of them, are a little bit shorter, some of them a little bit longer, but you get the fundamentals of clinical bedside care as well as your biological, your biosciences. Um, and then your role is, of course, according to your Nurse Practice Act. And generally speaking, LPNs will either work under the general supervision of an RN or a healthcare provider, depending on where you work. Okay, so with that being said, like most of the time, you will work under a registered nurse. But when I worked in peds, I didn't have an RN supervisor. I worked directly with my provider. So my doctor, my MD, he was actually my supervisor. So when we look at different roles, the roles of the RN, I think I talked a little bit about this already, but they plan care, they coordinate all the activities of care, including care from the interdisciplinary healthcare team. They provide care that requires more specialized knowledge and judgment. They teach, right? And then they act as that client advocate. LPN, you guys are going to practice within your scope according to your Nurse Practice Act. You will provide care in basic and client situations under the general supervision of an RN physician, podiatrist, dentist, whichever you work at. Your primary responsibility in the care of vulnerable populations with chronic stable conditions, and then provide safe client care, serves as a client advocate, teaches clients, and communicates effectively, all while functioning as a collaborative member of the healthcare team. And I'm going to say that generally speaking, that you are going to provide care, right, with chronic stable conditions. More and more now, we are seeing that LPNs are having to care for clients that are in more urgent situations. And so building your skills, your critical thinking, your clinical reasoning skills are going to be super important. Role differentiation as far as care manager, RN controls decisions on staffing and client care. But I don't know if that's so I'll talk about NCLEX though in a minute, and I want to show you guys something now that you said that. Thank you. You reminded me. Because I don't know if I did this or not, but LPNs and long-term care are often the first line managers. Okay. LPNs are unit managers. They're sometimes even supervisors and assistant director of nurses. I've also seen LPNs in run assisted living facilities. Okay, so you do have an expensive role. Community care, first line manager, still will have some sort of a supervision. Okay. So that is something to, know as well. Provider of care. So the RN will, let me open this real quick. The RN can do all phases of the nursing process: assessment, diagnose, plan, intervene, and evaluate. So they are independent in all 5 parts of that nursing process. The LPN assists with all phases of the nursing process, but you can work in an independent role with your data collection and your interventions. Okay, so not an independent role when it comes to the nursing process and all aspects of it. Again, the RN is always going to be the one that initiates the health teaching. LPNs will reinforce and assist with health teaching as needed. And so like I was saying, your roles are, they're not limited. There's a lot of opportunities for the LPNs. Charge positions, supervisors, even assistant director of nurses in those long-term care facilities. So usually the RN will be like the director of nursing. There may be other RNs that are employed within the facility. But you assist with decision making, care coordination, as well as the assignment and supervision of your UAPs, which are your CNAs most of the time. So there are different delivery methods. And so what does that mean? So for example, before I left Virginia, I met with I was meeting with a clinical partner at one of the facilities, one of the managers of the units. And so I know, as you know, when I first became an LPN, or actually when I was in school for my LPN, they had started shifting LPNs out of the hospital. Okay. Um, and so I was obviously not able to go work in a hospital when I graduated with my LPN. And then we have slowly now seen it kind of came around 360, right? Because now we're hiring LPNs back in the hospital setting. And there's different types of care that is involved. So the one hospital, like I said, that I had met with, they were going to go to this team nursing. Okay. So as they were reintegrating LPNs into the hospital, they were developing on certain units, they were developing this team nursing approach where they had an RN, an LPN, and a nursing assistant. Okay. And each task associated with the level of nursing, right? Everybody had their specific job to do, right? So the CNA provided the basic IEL care, the LPN maybe do medications and treatments, and then the RN, whatever the role there, I'm just kidding, right, would do her as far as her care coordination. There's also total patient care, okay, where one nurse plans and delivers care, and we see this a lot in our ICUs. The nurse usually only has maybe 2 patients assigned to them, and they are responsible for all of the care to that patient. Okay, so that includes their ADLs, their bathing, and things like that. Functional nursing is assigned to complete certain tasks rather than care for a specific patient. So this could be, you have somebody that's coming in, they're just going to do wound care for the day. Or maybe you have one person that's just going to come in and pass medications for everybody. So it's certain tasks. And then primary nursing, that's 24-hour responsibility for planning the care of one or more patients from admission to discharge. And then we have care management or case management. Care coordination or case management, we're looking at achieving outcomes within a specific time frame. And so we have what are called clinical pathways, and those are tools that they use to identify incidents or other things that may occur at specific times to achieve those outcomes within a certain length of stay. And the case manager also is going to help them with resources from the community. They'll provide education as far as medications and treatments, making sure that they get their tests and their procedures done appropriately as well. And this can be any type of nurse, RN, LPN. So more and more, I started noticing a trend. Now, when I first did managed care way back, it was only RNs. Okay. And they wanted at least a minimum of a bachelor's degree. And again, as things have evolved, okay, we have LPNs now that are doing case management. Um, and so those are just more opportunities that are continuing to open. So for an example, my daughter, my youngest daughter is an LPN, and she when she had her first child, her goal was to go back. She worked OBGYN and she loved her job. Um, and then after she had him, she had this panic. She didn't want to put him in daycare. She wanted to stay home. Okay. While she was on maternity leave, she was applying for jobs. And she did. She got a remote position as what is her job? She's a health coach. Okay. And so she helps, she has a certain patient or client base. So she is like almost like a coordinator between the doctor's office and the clients. And so she helps them with medications. She follows up on their diabetes, and she's an LPN. She follows up on their, like, they're taking their blood sugars, what's their diet, they're in all of, any concerns, when I forget how often she talks to them or whatever, but and then go into the chart, and like if there's a concern, she can message the provider and, on behalf of the client. But it's a health coach type of position. It still falls under care management. If they have any questions, concerns, they can reach out to her. And she kind of just, helps to deal with it. So that is something. I mean, she did have, experience as a nurse, before that she had done long-term care, and then she went into OBGYN, and she really loved OBGYN. So, but yeah, so there's lots of different options that are out there. Um, there's also certifications for LPNs. Don't knock yourself down with that either. There's IV certification, there's long-term care certification. So just be aware that there are certifications that you can get to as an LPN. When we look at client-centered relationship, we know that the patient or the client is the, center of our nursing care plan, right? But it is providing care that is respectful of and responsive to individual client preferences, needs, and values, and ensuring that client values guide all clinical decisions. So again, that's right. The client, it's putting the family and the client at the center of healthcare. And this includes their needs, their preferences, as well as making sure that they have all the information they need in order to make an informed decision regarding their care. Again, knowledge is power. The more knowledge you give to somebody, the more powerful it is for them. Other just important concepts from this. Each member of the healthcare team provides a valuable service. Okay. So from dietary, environmental services, to the nurses, to the providers, everyone is equal in importance to each other. Everybody has a specific role to perform. And so understanding where the LPN or LVN fits into the healthcare team, just looking at educational background, roles, responsibilities, licensing requirements really helps to understand, where you fit in. And like I said, I mean, I remember as an LPN, I had even, my mom was an RN, and her identical twin was an RN as well. And they were like, well, how are you getting your LPN? They're going to phase LPNs out. And, I did get a little bit of that, but you know what? Look how long it is now. And LPNs are still part of the heart of healthcare. And so, like I said, they're just recognizing it even more and more, what an important role LPNs play in patient care. And, I know some of you plan to go on and get your RNs and nurse practitioners and all those wonderful things. And I love that for you. And I think that's amazing. But don't ever knock your role as LPN, because you guys are needed, 100% needed and respected in healthcare. And I just want you to know that. All right. So This last little bit, have a little bit of a communication case study. So this one's going to be a little bit different from earlier. So here we go. So we have Jordan, an LPN, is assigned to care for Mr. Reynolds, who is a 68-year-old patient admitted with pneumonia. Mr. Reynolds also has a history of COPD and anxiety. He frequently asks questions about his care and often uses the call light. During a particularly busy shift, Jordan becomes frustrated with a repeated request. When Mr. Reynolds asks for clarification about his medications, Jordan responds in a rushed and dismissive tone. I already told you what they're for. You need to relax and stop worrying so much. All right. So call light pressed again. So later, when Mr. Reynolds presses the call light again for shortness of breath, Jordan delays responding, assuming the patient is being overly anxious. When Jordan finally enters the room, Mr. Reynolds appears visibly distressed with increased respiratory rate and decreased oxygen saturation. The RN is notified and rapid interventions are initiated. Outcome: Mr. Reynolds requires escalation of care, including increased oxygen support. He expresses fear and distrust towards the nursing staff. He later reports feeling ignored and talked down to in a patient satisfaction survey. The incident is reviewed by the nurse manager due to concerns about delayed response and communication style. All right, so some of the key issues that were identified. Use of dismissive and non-therapeutic communication, failure to actively listen to patient outcomes, assumptions about patient behavior, right? Labeling them as anxious, delay in responding to a potentially serious symptom, and a breakdown in trust between patient and nurse. So, what specific communication behaviors did Jordan demonstrate that were ineffective or inappropriate? So what behaviors did he exhibit that were ineffective or inappropriate? I can go back. So here he responds rushed and dismissive. And then here, right, he delays responding, assuming the patient is anxious. So, whoops. Right? I've already told you what these medications are for. Okay. How did Jordan's communication impact patient outcomes? What could he
It
have done better?
impacted it negatively, and he could have also taken time to not take his patient's feelings personally.
Not just right. I mean, we talked about that earlier, right? About projection, right? Labeling those clients as difficult, right? Or annoying. What cues did Mr. Reynolds exhibit that were overlooked? I can go back. Oops.
He was overly anxious.
Right.
So that's probably one of the first signs of what is called the first signs of hypoxia, being
Right.
relentless.
Good job. Yep. Oops. And then what should the LPN have done differently when the patient used the call light repeatedly? This is a good one. What
He
could he
could
have
have
done differently?
he could have actually assessed him, like actually taken a focus assessment for his respiratory if his diagnosis is COPD and he's anxious.
Right. Actually, just taking the time to really kind of see what is going on, right? And this is why I said, some of those patients that can be a little bit more difficult, right? We may tend to ignore them. And we know that communication can lead to safety risks, as we just noticed within this. So again, that therapeutic communication, it's active listening, it's empathy and respectful responses. Patients with anxiety and chronic illnesses may require additional reassurance. Frequent call light use may indicate unmet needs or worsening condition, not just attention speaking. And that delayed response can lead to clinical deterioration. And then, of course, we know communication directly affects patient trust, satisfaction, and safety outcomes. And we have to be able to recognize when to escalate that to the RN. And so I have another example. This is another, just a story from my experience. Um, so we had a patient. This was, again, it was a brand new LPN. Maybe I had maybe been working maybe a year. Um, and it was working on a skilled care unit. And we had this woman um who I had just started working with her. I didn't know her very well, and she was complaining of chest pain. So chest pain, of course, we worry about heart attacks and all that wonderful stuff. So I got her vital signs. Her blood pressure was a little bit elevated. That's all I remember at the time. Anyway, called the doctor, sent her out 911 to the hospital. Okay. So I go back and I'm sitting at the nurse's station. I'm doing my charting because this was paper charting. Okay. We had the whole big, the whole big patient record, and we had to write out all our nurses' notes. And so I'm doing my charting, and the other team, so I was a team leader, a brand new LPN, and I was a team leader. I know it's kind of, yeah. The other team leader for the other half of the unit, she comes up and she was like, I can't believe you sent her out to the hospital. And I looked at her, I was like, well, what do you mean? And she's always complaining of chest pain. There's nothing wrong with her. This is just her crying wolf. And I'm like, okay. And so, of course, now I'm like double guessing myself because I'm already a new nurse, right? And I'm, don't know it all. And so I went through this whole thing and I'm like double guessing myself. And oh my gosh, I just wasted all these valuable resources sending her out 911. And then the DON comes up because the DON had heard the conversation. I didn't know she had heard the conversation. And she walks up to me and she says, hey, I just want to let you know. That the resident was admitted to the hospital to rule out a heart attack. And so I'm like, okay, that makes me feel a little bit better. She eventually came back to the facility. She actually did not have a heart attack. Um, she wasn't even, let's put it this way, they didn't even diagnose her with angina. Okay. So she comes back to the facility. And she never complained of chest pain again on my shift. But she had complained of chest pain on other shifts. And um, I don't remember exactly, but then eventually she got transferred off the unit and she went to a long-term unit. And so, long story short, because of her previous behaviors, and complaining of chest pain, um, the one time that they decided not to send her out to the hospital is when she had a heart attack. So you never know, right? Um, we sometimes label, like this scenario says, we sometimes label these patients as difficult or overly anxious or scary, just scared, depressed, whatever it is. The best advice I can tell you is think about it if we're you, okay? And I know that's, when you look at it, but nobody wants to be in a long-term care facility. Nobody wants to be there. Imagine that's you, and you've had to give up your home and all of your belongings because you can't bring it all into a long-term care facility, right? You go from a house or even an apartment into, excuse me, into half a room, right? In most cases. Um, So there's a lot of anxiety. There's a lot of change that occurs in the transition into long-term care. The loss of freedom, right? Of course, they have rights and they can do the things that they need to do, but it's still a huge loss. Um, and so when we look at them, being needy, a lot of times it is just that unmet need and trying to find ways to assist them. And not everybody's going to have a heart attack or go into respiratory distress or something along those lines, but we really have to be careful with how we label our clients because we want to avoid those negative connotations. All right. Any questions about today? Oh, it when we're working with those clients, it's really about being empathetic. And so I've had them. And I will tell you, I'm not gonna lie, there have been times I have stood outside the residence door and just had to have a woosah moment to be like, I've been in this room 15 times today, right? What is it that they could possibly need? Um, a lot of times it's just knowing that you're there. And I literally just walked in and said, Hey, Mr. Smith, what do you need? And they're like, I just want to make sure you are here. Or, just to sometimes know that there is somebody there because it can be very scary, especially in that first transition. And so, yes, sometimes it's just they need to know that when you hit the call though, that somebody is going to come. And after, I will tell you, after a while, it starts to die down. The first couple of days usually is the worst. And then once they start to like settle in and relax, it does get a lot better. But it's just a lot of reinsurance. And like I said, it's very easy to get frustrated. I'm not gonna lie. It is easy to get frustrated, but you have to understand that they're in a place that they're unfamiliar with.